far here, pneumococcal meningitis mortality is very high. Most authorities put it at 50 to 70%. And there's some review I did some years ago that it shows that in Nigeria, I think in Zaria, David Warrell found about 50%, in southwestern Nigeria, 51% dying. Not the rapidity of dying, but the frequency of dying is very high, so to say. Here, Neisseria meningitidis mortality is a lot lower. It's 10 to 20% compared to, say, pneumococcal. Increasingly, we are seeing pneumococcus as a cause of outbreaks, especially in Ghana. We know that globally is the commonest cause of acute bacterial meningitis, sporadic meningitis, while Neisseria meningitis is the commonest cause of epidemic forms of meningitis. But increasingly, we are seeing pneumococcus even in outbreaks. Here, I think one of our colleagues, Dr. Rahma, is auditing LP because our LP frequency is very, very dismal, and how we process CSF and reporting of CSF. At times in the lab, you see they say cell count per cubic millimeter. At times they say protein per deciliter. At times they say protein per liter, which is confusing. There is need for standardization. By way of antibiotic selection, usually empirically vancomycin, ceftriaxone in adults or cefotaxime in children, plus minus ampicillin, if you think Listeria is likely, should be considered. The use of adjunctive steroids, dexamethasone, very useful in high-income countries, reduces mortality, neurologic sequelae, hearing impairment. But in Africa and in low-income countries, it has not been shown to be useful, and it's a number of reasons have been ascribed. So Brian Greenwood wrote a very interesting article that perhaps it has to do with delayed presentation, the organisms, the high prevalence of HIV, and limited access to critical care. It's something that's still needed to be studied, because I think there may be patients who may benefit from the use of steroids, so to say. The other area is that of Lemaire's disease, soft tissue, space-occupying lesions, infections such as Lemaire's and Ludwig's. Here you see traditionally stromboflebitis within the jugular vein. Mortality could be very high. Organism is usually Fusobacterium necrophorum, and not uncommonly, mortality may result. They also have septic emboli to the lungs, to the chest, and you may have to differentiate it from Ludwig's angina. Ludwig's angina tends to be above the pretracheal fascia, and the organism range may be different. Strep viridans is more usually the organism causing Ludwig's, while Fusobacterium necrophorum is the main organism in the case of Lemaire's disease. Here again, we have to work with maxillofacial surgeons, dentists. In Kano, we've seen a number of cases. I'm following traditional tooth removal. They go to a traditional dentist, and he used funny equipment to remove the tooth, and then eventually they get infected. We saw one, the whole trunk had to be debrided. The infection stretched from the neck down to the whole trunk. This is also something we need to be wary of as clinical infectious disease practitioners. By way of advice, antibiotic advice, amoxicillin clavulanic acid, unless it's modified by drug-resistant pathogens. And if there is allergy, you can use Cipro of levofloxacin plus Clinda, or you may use Astrenum plus Vanco if MRSA is likely. The next is acute rhinocerebral mucormycosis. Here you have rapid neurologic complications with cranial nerve pulses, with coma and focal deficit, multiple cranial nerves affected. You have to involve many groups, ENT, ophthalmology, MFU at times, and you have to do wide margin debridement, at times exenteration and extirpation. You have to also drain the sinuses. High-dose amphotericin is used. Both fluconazole and voriconazole may not be useful. The only azole of promise is posaconazole and echinocardin, such as caspofungin. Some years ago, as head of department, they literally were nearly sued A patient came, a banker from Zenith Bank, I never forget, 38 years old, obvious near-onset diabetes, DKA, and in front of our eyes, literally, with acute rhinocerebral mucormycosis, multiple cranial nerves, was in ICU, and then he died. And then a month later, the CMD got this letter from Zenith Bank. Why should so person die? And we had to explain why he died. And we said, even in the best of facilities anywhere in the world, really the likelihood of dying is very high. And we found that every subspecialty in medicine, so nephrology, endocrinology, ID physicians, and also ENT, ophthalmology, maxillofacial, they also, but debridement actually was not done. And our antifungal agents did not work, did not save that particular patient. Next is malaria. These are the severe manifestations of malaria, coma, distress, hypoglycemia, renal failure, among others, acidosis, and then you could have supporting such as jaundice, prostration, hyperpyrexia, and hyperparasitemia. And the cerebral malaria, on the other hand, will come with these features: coma, convulsions, abnormal posturing, disconjugate gaze, retinal hemorrhages. And Kevin Marsh in Kenya, in eastern Kenya, some years ago, looked at severe malaria in children because children don't have any form of immunity. And he found these are the major manifestations and the likelihood of dying. Respiratory distress is even way ahead of cerebral malaria in causing death. And some years ago, we also confirmed this respiratory distress in non-immune adults. It's a bona fide medical emergency and it kills patients. We saw a number of cases, at times Chinese timber merchants going to Gabon without any prophylaxis, coming back comatose and dying, and you have respiratory distress. We had about 20 or so such cases, and the outcome is dismal. But here, respiratory distress was about 4 times more likelihood of dying, cerebral malaria 3 times more likelihood of dying, among other things. And case fatality in malaria, about 20%. Even among survivors, you will have deficits, as in these pictures belonging to Sir David Worrell. This is in Nigeria. You could see cerebral malaria. You could see them with all sorts of signs: broken neck sign, prostration, doll's head phenomenon following cerebral malaria. Another is to pick out retinal hemorrhage as a predictor of severe malaria. Unfortunately, many of our hospitals, including mine, do not have regular ophthalmoscopes. So this art of picking retinal hemorrhage is dying among physicians. This is very, very bad, and it's something that I think we need to do more about. This is even on recovery. They will have deficits. And in non-immune adults, when they have severe malaria, either the respiratory variant, you may have to do exchange blood transfusion. Although in population studies, the evidence does not suggest that it may affect survival, but in individualized cases, World Health Organization recommends that for those with parasitemia rate of over 10%, they should be considered for exchange blood transfusion, assuming you'll have regular blood, HIV negative blood supply, hepatitis B blood supply that is negative, and syphilis negative blood supply, because there are many other operational considerations. Recently, we found that many groups are not quite satisfied with the regimens for managing malaria. And as we speak, there are ongoing randomized controlled trials in Ghana to see whether we make it, we add at least 2 other agents in the management of uncomplicated malaria, a randomized controlled trial of artemisinin, lumefantrine, plus atovaquone and Fancida in one arm, and in the other arm without. They are recruiting, I think it's advanced. And in the second study, even for severe malaria, there are many groups feel that artesunate alone may not give the best outcome. So they are trying addition of clindamycin plus fosmidomycin. This is also recruiting right now. The studies are conducted in Cameroon and in Gabon. Lassa fever, it's another on that list. It comes with this features the swollen baby syndrome. This is a George Akpede's picture. You could see bleeding, you could see swelling, and from Irua, you could see the mortalities of about 30 to 37 among pregnant women, and in adults from 24 to 30. And you could see the major predictors of mortality: bleeding, shock, AKI, and encephalopathy. And these are the factors associated with poor prognosis there: high viremia, transaminitis, bleeding, encephalitis, edema, and third spacing, and third trimester pregnancy, and AKI. Ebola, the one we had in West Africa, had a lower mortality compared to the one that appeared in 1976. Mortality of about 40% was witnessed in the Sierra Leone, Guinea-Conakry outbreak. But in the one in Central African Republic and in Eastern Congo and Uganda, it could go as high as 70%. And usually the pathogenesis is not dissimilar to that of other viral hemorrhagic fevers: infection, immune dysregulation, volume-related changes, and DIC. And the management entails correction of these other pathologies, fluids, electrolytes, symptomatic treatment, and multi-system support. And there are a number of agents: the ZMapp, the favipiravir, the remdesivir, the Tecmira have been tried, and also vaccines, fairly good vaccines, especially the chimpanzee derived vaccine was used in ring control in communities in Eastern Congo, and it was found to be useful. But there's another actually that we participated in an advisory for Jensen Silak. There is some promise in these vaccines. I'm sure Prof. Demi will has more experience with these agents. So as I conclude, I made this composite, which even if you didn't listen to the lecture, please try to look at this particular slide. It has two rankings. The first rank is how fast it kills. The 12 diseases are given a ranking 1 to 12. The one that kills the fastest is given 12 in the first two columns. And in the latter two columns is the frequency or the probability of dying from a disease. It's also given a ranking of 1 to 12. The one that has the highest probability of dying from the literature is given 12 over 12. And then you have a composite of the rankings 11 plus 10, as in the case of gas gangrene having 21. So out of this analysis, gas gangrene from Clostridium septicum, I must say it's a biased because I took Clostridium septicum. Somehow the one that I said causes non-traumatic gas gangrene came out the highest priority. And second, sepsis in the immunocompromised. Here you could see that how fast it kills within 12 hours. The mortality is high as 50%, scoring a 9, and you have a 19. And then the next two diseases all had a 19 score. Acute meningococcemia also kills so fast, 24 to 48 hours, a ranking of 8, and the probability of dying 11 of 12, giving you a summation of 19. And necrotizing fasciitis due to group A strep kills the fastest of all the lists, as mentioned earlier, 12 over 12, kills within 12 hours. And for Staph aureus, however, it doesn't kill that fast. It gives you 24 to 48 hours. But the probability of dying is just 35%, bringing it down with a score of 7, giving you a total ranking of 19. And then septicemic melioidosis. In the past, we said it's not in West Africa, but we've seen studies now suggesting that this is something we are missing, and our colleagues in microbiology should pay attention. By way of how fast it kills within 48 hours to 5 days, and got a score of 3. And by the proportion of who die, as I mentioned earlier, 80 to 90%. So even if you use 80, that gives it the highest score as regards the probability of dying, 12 over 12, So given it a summation of 15. The septic shock and sepsis. You have urosepsis, hepatobiliary sepsis, and pneumonias coming to 13. You have acute rhinocerebral mucormycosis getting a 13 also. You have toxic shock syndrome. Here again, it should be noted, group A strep kills much, much more than Staphylococcus aureus toxic shock syndrome. A comparison, if you look at to the right-hand columns, 30 to 70% from group A strep toxic shock die compared to 5% of Staph aureus. So a total score of 12. And then acute bacterial meningitis, strep pneumo and Neisseria meningitidis. As I said, strep pneumo is by far the one that has a higher proportion of dying, and it had a summation of 8. And viral hemorrhagic fevers, Ebola virus disease, Lassa fever coming at the stage of 7, noting the Ebola frequency of dying, I use 40 to 70%, while Lassa fever 24 to 37%. And if you come to the next, is severe malaria. It's coming to the second to the last, I think, with 5. And last but not the least, space-occupying infections, especially Lemaire's syndrome, coming with a score of 5. So, ladies and gentlemen, these are some of the infections that we cannot afford to miss and we should pay attention to. And in concluding, some of that really we are not doing as well as we should be doing. The probability of surviving severe infectious disease is low anywhere in the world. It's not unique to us, but it's even lower when you are in Nigeria. There are major challenges in microbiologic detection, characterization, provision of susceptibility testing, and the turnaround time for many of our investigations is too slow to survive a serious clinical infectious disease. There are diagnostic challenges, especially associated with processes, procedures, LP, cerebrospinal fluid processing, echo, imaging, serum lactate are lacking. Access to antimicrobial agents is limited. Only vancomycin we have for MRSA. Many alternatives are not there. Even vancomycin, at times we have to send to Lagos or Abuja from Kano. Antifungal agents, we only have fluconazole, and it's probably not the drug of choice for many of these fungal infections. You had fluconazole and voriconazole are not useful for rhinocerebral mucormycosis. And most importantly, I think, our knowledge, my knowledge as an infectious disease doctor, and I suspect many other colleagues' knowledge, either in clinical ID or in clinical microbiology, really leaves much desired. Our idea and attitude of failing to involve colleagues that these diseases require multidisciplinary approach to care needs to be emphasized. Antimicrobial stewardship, a rational use of anti-infectives is often limited and lacking in many tertiary facilities. And I think professional societies such as ours should take up these challenges towards improving care for patients with serious infectious diseases. I acknowledge my many colleagues over years at our unit, Professors Ibrahim Neshabaru, Professor Mohammed Hamza, Professor Garba Ilyasu, and colleagues at Department of Medicine and also Department of Medical Microbiology, especially Dr. Blessing, who we work with very closely at Bayero University and AKTH, and also residents, many residents over years, I think last count about 40, but notably at this stage with us, Dr. Akambi, Dr. Edward, Dr. Yusra, and many others. And also I've used images and slides from many colleagues, Professors Fatima Hassan Hanga, Professor Garba Ilyasu, Dr. Abdul Malik Murtala, Dr. Amina Shuaib, Dr. Rahma Isiaq Umar, and Sir David Warrell slides on malaria. On that note, I hope I've been speaking to you, not to myself. I hope my connection has been sustained through. Thank you very much. Thank you.
Thank you very, very much, sir. This has been a very, very wonderful presentation or an eye-opener to every one of us. So I don't know, maybe we'll take questions. If we have any questions, we can just, raise our hands and then indicate that we want to ask, or we want to use the chat box to send in our questions. So while waiting for that, I want to say that, sir, what you have mentioned can never be underestimated, because I think one of our major challenges in terms of, making diagnosis of emergency, whether emergency infectious disease or non-emergency infectious disease, mainly or solely rely on how well our clinical or medical laboratory is. Because once we don't have that in place, it means that we'll miss a lot of infections, we'll miss a lot of, cases in terms of making diagnosis, which you have strongly emphasized on that. One other major thing that you have mentioned is the use or misuse of antimicrobials, that we are all culprits of that. And we all know last week was, the week of celebrating or marking that's World Antimicrobial Resistance Week. And then it's something that we need to keep at the back of our minds, to know that once you are dealing with any, clinical scenario, whether it's infectious or not infectious, you have to make that decision of when you want to use an antimicrobial. Because by using irrational use of antimicrobials, it means that we'll just keep on increasing the risk of resistance, which will now leave us to limited resources in terms of treating our patients with. So thank you very much, Prof. We are very honored to have you and then to give us that presentation. So please, if we have any questions, we can indicate either in the chat box, or we can just raise our hands and then ask our questions. Thank you.
Yeah, okay. Dr. Zainab, I've seen some hands raised. Seen George Mukoro.
Okay, okay, I'm trying to see that. Okay, George, please, if you can, go ahead and ask your question. Thank you. Hello, George, can you hear us? Okay, can we move to the next person? Kabru Mande Mohammed.
Hello.
Yeah. Hello.
Hello.
Yes, we can hear you.
Oh, okay. So good day. My name is Professor Abdusalam Nasidi.
Welcome. Yes.
Congratulations to the
Good
speaker.
afternoon, sir.
Good afternoon. I'm very proud of all of you. It's a wonderful presentation. I learned a lot. I just wanted to add that as regards Ebola, we developed in collaboration with Oxford University and the Microfarm group in UK a treatment called Ebotab, which actually is a treatment to neutralize the Ebola virus. It is an intact ovine immunoglobulin G, meaning it's a type of antibody derived from sheep that has shown promise in neutralizing the virus in laboratory and animal studies. Ebotab has been tested in guinea pigs and cynomolgus which researchers developing this as a cost-effective potential therapy for Ebola infection treatment. We have virtually gone through most of the WHO pre-qualification, and I think I will seize this opportunity to request Professor Habib to see if we can actually bring it into Nigeria for clinical trials and some testing. Then on issues of microbial resistance and the new developments worldwide, I strongly believe that I'm so happy seeing most of the publications coming from Nigeria, and please keep it up. Thank you very much.
Thank you very much, sir. So do we take comments, questions first, Dr. Zainab, before responding? Or
Okay.
what do you want?
Sir, whichever way you want it, sir. If you want to take all the comments and questions first, or you want us to write it down.
Yeah, I think it's better to take tranches, like 3 or 4, then respond.
I'll take call, sir.
Okay,
Hello.
sir.
Yes.
Yes, George.
Can you hear me now?
Sorry, Prof.
Yes,
George,
we
are
can.
you able to
Yes.
speak now?
Yes. Can you hear me now?
Yes.
All right. Thank you very much, Prof, for this very elucidating presentation. I have some concerns with the clinical entities that were mentioned. In my own little experience, I've noticed that on the surgical side, we've been having a multi-drug resistance metastatic abscess, where the primary site of infection is different. And then there's another clinical entity in another part of the body with the same infection. By the time you collect sample from both sides, you'll be having a positive microbial growth with multi-drug resistance. So, and in these clinical entities, which I noticed the society is very much concerned about, we've not made any comment on that aspect, possibly because the surgeons will still need to do more close collaboration with the other departments concerned with infectious disease in order for us to have these clinical entities reported. That's my first observation. Then, sir, I would like to know if tissue biopsy for microbial investigation is more important than a swab MCS. Looking at our experience, it seems most of the labs do not make requests for the tissue biopsy. And from what we've gathered, it seems to be more positive when identifying those implicating organisms. And finally, sir, is it possible for PCR to be a routine investigation, especially multi-drug resistance is now becoming a common norm among our implicating organisms? Thank you, sir.
Okay, thank you very much, George. Can we, sir, or should I read the question on the chat box?
Yeah, actually, my internet faltered, but you can raise it. Yeah, I'm back now on a hand phone. Excuse me.
Okay, sir. So I don't know, should I read the question in the chat box or we should?
Yeah, okay, you can.
Okay, so this one says that my question is, in ID cases, how do we balance the need for broad spectrum empirical antibiotics with the AMR crisis, especially in low resource settings?
Yeah.
Yeah.
Well, it's a very important question, but I guess it's the whole idea around antimicrobial stewardship and also knowing the severity of the infections you are dealing with, whether or not it gives you the time to somehow consider anti-infective sequentially rather than all at once. If you're dealing with very serious high mortality, high fatality infections, really there is no margin for using antibiotics sequentially. You rather use them concurrently. If you look at the example of acute bacterial meningitis, where we said the recommendation is to use vancomycin, ceftriaxone, plus ampicillin, if you are not sure. One, because drug resistance with strep pneumo means that you cannot afford to use penicillin or ceftriaxone alone. You may have to use an agent that is reliably effective even with high-level resistance, such as vancomycin. And you cannot afford not to treat Listeria monocytogenes if he or she has meningitis. And both vanco and ceftriaxone have no activity there. So you have to use ampicillin or cotrimoxazole in addition. So where you have a serious infection that can kill within few hours, really you have to somehow use antibiotics rationally, but in combination. But if you have an infection that can give you time, that is not known to kill easily, potentially you may select antibiotics. You may not even use an anti-infective at the beginning. It's only later when you have some certainty that you may consider using an anti-infective in a sequential way. And also even where you use several agents, other aspects of antimicrobial stewardship will be that the moment you started all these three, thinking is empiric for meningitis, but later a CSF came back and said it's Neisseria meningitidis sensitive to penicillin, automatically you should step down all of them and use penicillin rather. So, but if the turnaround time to get the CSF, it's not good enough, you potentially may not necessarily be able to do that. But you have to do sequential therapy, you have to do switch therapy to try and ensure you narrow and simplify and reduce the number of anti-infectives you are using. If, on the other hand, you have a drug-resistant isolate, you have to use antibiotics that are effective on it. My other comment, sorry, before I went off, Professor Abdusalam Nasiri is our senior colleague, our mentor, and he's been at the forefront of this, the development of therapeutic antibodies, initially for a number of agents, initially for snake bites, and also for the Loughborough relapsing fever, as I was saying, in Ethiopia, and for the Ebola virus disease. I think this is a very welcome development. I believe this antibody is a polyclonal rather than a monoclonal antibody, but I'm sure we can subject it to clinical trial. As our president will tell you, however, these infections may not be predictable when they come. Prof. Abdusalam Nasiri, for the purposes of our attendees, he was the one in charge of the CDC and the containment effort of the Ebola virus disease that came or affected Nigeria some years ago, 2015 or so. But I agree with you entirely, sir. Thank you.
Okay,
Yes, Dr.
sir,
Zainab?
maybe, yes, sir. Before your network went down, there was George asked some very important questions, and he made a comment, which unfortunately, I don't know, George, if you're still with us. I will read the questions that you have gotten. So he was asking, what is the role of, tissue versus, swabs when it comes to tissue, wound site infection or surgical site infections? So he was asking, yes, which one is more superior? Because from his knowledge, he knows that, the tissue is, the most superior in terms of making diagnosis of, microorganisms. But unfortunately, our labs are still, still comfortable with accepting swabs as means of diagnosis of, infections.
Dr. Zainab, you should have answered this question. But on a serious note, it's a major issue, and it also speaks about the tragedy of the commons, if I may use the word, for Nigeria. We all know that preferably samples from sterile sites, such as deep tissue, such as CSF, such as blood that is well taken, should have been the way forward. But oftentimes, if you insist to wait for a CSF, you may never have one. Or if it's taken, it may be stood there at the nurse's stand for 2 hours before it even reaches the lab. So I agree with you entirely, George, that ideally we should take from deep tissue rather than from the surface. For the surgical site wound infection, we use the swab, we put it deep in, and you may have to clean even the periphery and the superficial surfaces to ensure that it's not an isolate from the surface that you are taking. You recall that we have this so-called probe test, where you may have to put a probe that is able to touch the deeper part, perhaps the bone. So from that probe, you bring it out and send it to the lab immediately, not to stand it at the nurse's stand for another hour or 2 hours before it's processed in the lab. So there are so many issues, and this is what I meant by there is issue of knowledge, there is issue of attitude, there is issue of practice, there is issue of our capacities, all of us. So this we have to do. And then you recall when you say tissue, if I'm looking for a surgical tissue, before I get a surgeon now to come and convince him that he should take that tissue, it's not an easy thing. At times, a lymph node, they'll tell you it's better you do a fine needle, while you know it's better to get an excisional biopsy, to get a deep tissue. If you consider it could be a fungal infection within the sinuses, for instance, you want some aspirate, it may be very difficult to get a maxillofacial surgeon to come around to drain that or to get a sample from that. But I think we have to persevere and we have to educate, we have to train, we have to continue to retrain. And we have to also continue to change attitude. Thank you.
Thank you very much, sir. And then his other question is, can we use PCR as a routine, method of analysis in terms of making diagnosis of infectious diseases?
Yeah, this is very pertinent. There are many real turnaround time PCR-based tests, multiplex tests, and they've come in use. I think last year I did present on that at the American Tropical Medicine meeting. Many of them are RDTs, are lateral flow assays, even if not molecular, they are immunologic, and they can be used. You recall there is the Binax for pneumococcus, for instance, and there are also other antigen-based tests. You have the urine for histoplasma for mediastinitis, which will tell you whether it's histoplasma. There are many other bacterial rapid tests, diagnostic tests that are now commercially available and are used, and they could circumvent the use of lab. And as you know, increasingly also the use of artificial intelligence and machine learning is threatening the conventional laboratories, and you may have algorithms that may be able to give you predictions as to organisms. Yeah, it's a very relevant question, and I agree entirely. You could have PCR-based tests and immunologic-based tests that could be used as circumvent conventional labs. Thank you.
Thank you very much, Prof. I remember Dr. Mohamed Sani and then Kabru Mande, your hands were up. I don't know if you still have questions or your questions have been answered along the line of discussions.
Yeah, thank you, Dr. Ozena, for recognizing me. This is Dr. Mande.
All right, thank you.
Yeah.
Go ahead.
My honest comments. First of all, congratulate our father and teacher, Prof, for this very important lecture. And I use this opportunity to remind him and to make his day good about one particular case we managed when I was under him, training with him in Kano, about 16 or 17-year-old girl who came with meningococcemia. She was about to write her WAEC, and we successfully managed her. She developed so many of those complications Prof talk about, including septic arthritis and the skin manifestations, and eventually we were able to successfully treat her and manage her, and she wrote her WAEC subsequently, and the family were very happy. Just to remind Prof about this very successful care we were able to undertake.
Okay. Thank you
very much, Dr. Kabir. I hope to come to Zamfara to meet up with you and have that dinner. Thank you.
Okay, Dr. Mohammed, are you still on the call? Because I saw your hand earlier up. If you're still there, you can ask your question. Okay, in the absence of that, there's a comment in the chat section. There appears to be increase in frequency of necrotizing fasciitis. Is this due to increased risk factors or increased health-seeking behavior? So, Prof, I don't know if you want to make a...
Yeah, I think really there is also heightened awareness. Perhaps we may be missing necrotizing fasciitis. As I was saying years ago, as a resident in Zaria, we saw a number of these cases, and they come and die so fast. At times, they don't get to even come out from the rural areas. They die. Group A strep or strep pyogenes has many faces. You'd recall it's the one in rheumatic heart disease, it's the one in glomerulonephritis, the immunologic components, but also the infections, the invasive part. And for whatever reason, immunologically, its toxins in necrotizing fasciitis is severe. And also its toxic shock syndrome is also severe with a very poor outcome. As I discussed while working in Singapore, really, it's the one thing we never send a patient with a rash and fever home until we exclude necrotizing fasciitis, because you'll be sued. And the patient is likely going to die or to lose a limb. So you do not want that to happen. You have to exclude necrotizing fasciitis. So I guess the awareness is there. I recall one particular case wherein they ended up in court and they had to bring in the world expert on necrotizing fasciitis, one Dennis Stephens. He gives the chapter in Mandel on necrotizing fasciitis, and he gave expert opinion and evidence in the court that really, even anywhere, even in the best of centers across the world, the likelihood of surviving if you don't pick it at the beginning, it's really nil. Patients will go on to die. So yeah, it's increasingly common, but we shouldn't confuse it with the type 1, type 3, and type 4 forms of necrotizing fasciitis, which are not as virulent, not as aggressive. And as mentioned, all the Staphylococcus aureus form of necrotizing fasciitis, which is sort of slower, less aggressive. Thank you.
Okay, thank you very much, sir. I think with this, we have come to the end of this session. So we'll now take a break and then reconvene at
Sorry,
2.
can I just make a comment before we
Yeah,
close?
I've seen the chair. I've seen Professor Idris Mohammed in the audience. I think it's
Okay,
the chairman. I don't know, the chairman, board of trustees. I don't know whether it's him or another person. Thank you. Yeah.
Thank you, sir.
It's me.
Oh,
It's
thank
me,
you, sir.
Habib.
Thank you for coming. Another of my mentors in the audience.
My pleasure.
Yeah.
Thank you, sir.
It's good to hear you, as always.
Thank you, sir.
So can I make a comment, please?
Yes, sir. Yes, sir.
Okay, thank you very much. I think it's important to appreciate Professor Habib for this very loaded presentation. As you can see, it's very practical, evidence-based, contemporary. He had clinical stories, personal examples, and he has emphasized many aspects of what we ought to know, not just as physicians, not just as ID physicians, but as a clinician, irrespective of your discipline. And I think there are so many lessons that we need to take home as ID practitioners. One area he has emphasized is the need for multidisciplinary approach in the care of patients that have an ID pathology. And this is very key. And the need for us to build capacity and competencies in various areas of the care of patients with different types of IDs, especially when they are emergency related IDs. I think one way that we can take home the message he has given is for us to consider, with the permission of Professor Habib. I think it's important that we have such like a framework or a document that speaks to these presentations that are going to be given and what you are giving, i.e. A short overview of the key points from this presentation that will be useful to clinicians that would ultimately adopt the messages that you have presented to care for their patients. And so what I'm in essence saying is that if the organizers can work with you, sir, to come up with maybe a 1-page or a 2-page document that summarizes the key points from this that we can subsequently circulate to all attendees and even be part of what we can publish in our website as key areas that clinicians need to note in the management of ID emergencies. So I think it's also important to acknowledge members of our Board of Trustees, Professor Idris Mohammed and Professor Nasidi and others that perhaps I have not seen here. I think on behalf of all of us, we want to appreciate you for finding time to attend this meeting. Once again, thank you very much, Professor Habib. I hand over to the organizers. Thank you, sir.
Thank you.
Thank you very much, sir, everybody, for joining this call. So take a break off and then reconvene at 2 o'clock to take the other presentations. Thank you.
Yeah. Thank you very much. Thank you.
Thank you, sir.
Thank you so much, sir.
ba ka sha ne ba.
Good afternoon, everybody. Welcome back to the afternoon session of the discussions or webinar. So in the afternoon, we'll be taking a lecture on AI. We know that AI is pertinent to our livelihood since we are moving into the technology or the IT area. So permit me to now introduce Dr. Bashir Isa Waziri. Dr. Bashir, who is a senior lecturer in the Department of Human Physiology at Bayero University, Kano. He is an emerging leader in cardiovascular physiology, genomics, and climate health research. He currently serves as the Deputy Director, Administration and Instrumentation at the Center for Biotechnology Research in Bayero University, Kano, and as a research fellow at the Kano Independent Research Center Trust, where he leads the Climate Resilience Action Group. Dr. Waziri has been an integral part or member of the team that has established the state-of-art genomic laboratory at the KRCT. His research focuses on genetic predisposition to major non-communicable diseases, particularly cardiovascular disorders, such as atrial fibrillation, coronary artery diseases, hyperlipidemia, and preeclampsia. He also investigates the biopsychological and molecular pathways linking climate-related stress to mental health outcomes, with strong interest in strategies that enhance physiological resilience in vulnerable population. He has been, or he is still, a recipient of several competitive awards and grants, which include the DRIP Research Grant, Directorate Research, Innovation and Partnership with BUK in 2021. He has also been able to receive the multiple outreach grants, that's the Physiology Society of the United Kingdom from 2019 to 2021. He has received other awards such as the International Development Support Awards, that's from the Psychophysiologic Society in 2025. Other awards are the Institutional Engagement Awards, that's from the Physiological Society, also from the Physiological Society of the UK in 2023 and 2024. He has also been awarded as the Best Researcher of the Year in Physiology from the Bayero University, Kano in 2024. Dr. Waziri is an active member of several prestigious international organizations, serving as a member in so many societies and organizations such as the Representative of Physiological Society in the United Kingdom, Climate or Global Climate and Health Alliance, Climate and Physiological Resilience Network, and the African Association of Physiological Sciences. He is also a founder and coordinator of the Basic Life Support Awareness and Training Campaign at the Bayero University, Kano. Internationally, he is also engaged. He has presented at major global platforms, including the Global Climate and Health Summit in London in July 2025, Physiology in Focus, in Newcastle in 2024, Future Physiology, Liverpool in 2019, and has trained at the world-class institutions such as the EMBL, EBI, and the Wellcome Genome Campus. He's a dedicated educator and researcher with over decades of experience. He has mentored countless students, coordinated high-impact research or scientific events, served at so many editorial boards, and received multiple national and international awards. Dr. Waziri is committed to advancing scientific excellence, climate resilience, precision medicine, and sustainable development across Africa at large. So, sir, if you're on the call, please, I'd like you to share your slides so that you can start your presentation. Thank you, sir. Hello, Dr. Bashir Waziri, are you on the call?
Sorry, Dr. Zainab. Dr. Bashir has some technical challenges, but he's changing the network. He will soon join us. Sorry, please.
Okay. All right. Okay, before he joins us, I would like to apologize on behalf of our third presenter, that's in the person of Professor Cesar de la Fuentes. He came down with some health challenges this morning, so unfortunately we won't be able to take the last presentation. So it's just for us to know that after this presentation, we'll now just close for today. Thank you.
In all the old familiar places, there is heart of mine embracing all day.
Hello, the technical support. Can you assist Dr. Bashir, the presenter? He said he's talking, but he can't be heard. I don't know if he's muted. Can you unmute him from your side? Thank you. Dr. Bashir, if you can hear us, please, can you talk?
Hello, this is Abdurrahman Huzaifa from the technical committee. Please, Dr. Bashir, please can you indicate by raising your hand so that I can identify you and help you resolve your technical issue? Maybe raise your hand or send us a text on the chat box so I can quickly identify you and help you solve your technical issue.
Hello, Dr. Bashir. Can you speak up?
Dr. Dalhat, are you sure he's on the call? Because I can't seem to find any Bashir there. Sir?
Yes, even me, I'm trying to see him, but I can't find him. I'm trying to chat him through WhatsApp to know which name did he use for the.
Okay.
I think you have the updated link.
Sir, did you say anything?
I was asking Dr. Rahman to make sure that Dr. Bashir has the updated link.
He has the updated link, sir. He was just sent another link earlier. So I'm sure it's the updated link he has now.
Recording in progress.
Okay. Only link ne daban ku.
No, probably.
National Section Annual General Meeting and Scientific Conference.
Yes, it's the one. If you can hear us, definitely, it's the same thing. Okay, no problem. Hello, Huzaifa. The technical support. Dr. Bashir said he can hear
Hello, I'm
everything
here.
we are discussing,
Okay.
but we can't see him. He said
Doctor, he's on this call.
He's into the call, but we cannot see him here.
Log in again.
He should indicate. He should just indicate so that I will know that he's the one.
He said he saved his number with Dr. Bashir Isa Waziri, and he can hear all our discussion.
There is no Dr. Bashir Isa Waziri on this call.
Yes.
There's no Dr. Bashir.
I don't know. I asked him to log out, log in again. Let me communicate with you.
Is he logged into this Zoom meeting, this Zoom call, or
Yes.
the YouTube call?
He even heard all what we are saying, discussing about him, that we cannot see him. We are waiting for him.
Can he contact me offline? Can you contact me on like WhatsApp so I will?
Let me talk to him again. Sorry.
Thank you.
You should have joined the first session. This technical gentleman discovered, but maybe he didn't join the first one. Hello,
Hello, sir. Yes, we can hear you. I don't think, yes, that's what I'm also thinking. Maybe he didn't get the link, but it has been sent to him, this very link that we have all joined.
Hello, Huzaifa.
Yes, sir. Yes, sir. I can hear you.
So I don't know what's the problem. I asked him to quickly link up with the IT guys in their center, but he said he can hear all our discussion. He's in the meeting.
Let him, Dr. Dalhat, let him tell us the name he has joined this meeting. Hagani,
let him indicate.
They can,
We're going to
yes,
resolve the issue now. You got his number.
He
Maybe
joined the
he's
link
on the
with.
live stream. He's on the YouTube live stream, not on the Zoom meeting.
Oh, yes.
Tell him to
Okay.
leave. because I was there
Okay,
before.
so let
Tell him
me
to
guide
leave the
him. Let me guide
YouTube.
him. Okay,
Let him
I
to leave
understand.
the YouTube
Okay.
completely.
So we've made contact with Dr. Bashir and we've discussed the issue. We've resolved the issue. He will be with us soon.
Okay, thank you very much.
Sorry, please. Dr. Bashir Ali was using the YouTube live stream, but we've guided him. He's going to join us soon. Sorry.
Hello, sir. Dr. Bashir, I can see that you're on the call. So if you are here, please, can you confirm that? Hello, sir.
Good afternoon, Dr. Bashir. Can you turn up the volume of your device and unmute the microphone so that you can hear us and then we can hear you? Or alternatively, the Zoom might not have permission to use your microphone or your speaker, so you can go to your settings and give it permission. Just depends on. That's why I wanted to contact you separately to tell you to help you with the issue.
Oh, but that's why we don't know how to do this. So annoying, so embarrassing.
Dr. Dalhat, what
Yes,
is Dr.
ma'am.
Bashir saying?
He joined. I saw him.
Yes,
I
I've
just
seen.
saw him cry. But it's like he was logged out again.
Oh, God.
I got sorry. Let me continue. The issue I don't know is like the people in IT in his institution are not close by. But let me continue to guide him.
What are his challenges? Can he share the challenges so that people here can help him join?
And the issue is he's talking. He said he talks, but we can't hear him.
It means, you know, he has to, that's his audio. He has to make it, or there's a way
I asked him to log out and log in again. Probably he didn't log in
to
with
do
his
that.
microphone.
Yes. So it's just let him click on that audio and then he will see all the options.
Yes.
So tell him to do that, please. Or Dr. Bashir, if you can hear me, please, you can do that. Just click on your audio and then see if he selects whichever, you know, speaker you want to use, depending on the computer. And then if you haven't given permission for your device, you have to go back to your settings, like what one of the IT guys mentioned. You have to go back to your settings and give permission for the Zoom to have access to your microphone.
Hello, good afternoon.
Good afternoon, sir. Thank you. At last.
Finally.
Finally, yes, sir. Thank you very much for joining us finally, even though we're a bit far behind schedule, almost about 30 minutes behind. So I think you can quickly, yes, you can quickly share your slides and then start with the presentation. You're welcome, sir.
Okay, thank you so much, and apologies, we have a lot of technical issues. So let me try and share my slides.
Sir, you might need permission. Okay, you're already there. Okay, thank you. Great. Thank you, sir.
So is my slide moving?
Yes, sir, it's moving. We can see your slides. Yes.
Okay. So thank you very much. So I am Bashir Waziri from Center for Biotechnology Research and also Team Lead Climate Resilience Action Group, Kama Independent Research Center Trust. So I was asked to talk about building research resilience, especially issues regarding leveraging funding and collaboration at the climate infectious disease interface. So this is not a lecture, but rather an encouragement and a call for experts among the participants and young researchers to come up together and build climate infectious disease research, and those research to be resilient in order to bring innovative solutions to our communities. So as we all know that climate change is reshaping the pattern of infectious diseases in several ways, including altering vectors and their habitats, increasing extreme weather events, which also affect AMR resistance because it might induce stress mutation pathways that could promote those organisms to develop resistance to antibiotics and so on. Climate change also intensifies human vulnerabilities due to displacements from one place to another, leading to overcrowding, leading to poor hygiene, and many other things that promote spread and of infectious diseases. So, although this is a challenge, but it will be an opportunity for innovation, resilience, and global leadership. So as we see it as a challenge, but in another way, it is also an opportunity for us, especially experts in infectious diseases, which I'm not. I'm just climate activist and then a researcher in genomics lab. So we need to build resilience and develop innovative solutions to address these challenges. So the purpose of the session is just aiming to stimulate and encourage participants to identify and secure funding opportunities and to see how we can build local and international research partnership and how to strengthen institutional readiness and develop resilient research ecosystem that is capable of addressing climate-driven infectious diseases. But why this matters? We all know, as I mentioned earlier, that climate change is intensifying, evidently by extreme heat weather events in most parts of sub-Saharan Africa, including Nigeria. And this has caused increase in vector-borne infections, waterborne diseases, and heat-sensitive infections. And despite these challenges, climate health research remains underfunded. I'm sure, yes, we have many funded research currently in Nigeria, but still, if we look at it holistically, the space, the climate and infectious disease space research is still underfunded, and these funding activities are fragmented, not consolidated, and not united in such a way that it will bring sufficient innovative solutions to our own challenges. And it also has, there is insufficiently integrated across sectors, meaning there are poor collaborations, because if you are talking about climate and health space, then there is need for collaboration of various experts from various disciplines, because they all have role to play. So, but the current scenario, the funding activities are usually fragmented and not fully bringing sufficient integration of multi-sectoral disciplines in this aspect. So based on this, there is a rising need for a resilient, adequately funded research network in Nigeria, and which is focused to address our local challenges and to build sustainable resilience strategies for the future. So we all know this is for, as experts in infectious disease, we all know that temperature increases accelerate pathogen replication, for example, malaria and some viruses, rainfall variability due to floods might lead to cholera outbreaks because of poor water hygiene and so on, and stagnation of water. And then droughts usually bring outbreak in meningitis. And during heat waves, there is increased antimicrobial resistance, as I mentioned earlier, because there is stress-induced mutation pathways. There are genes in these microorganisms that are stimulated and are expressed due to stress, and based on that expression, they cause mutations, certain antibiotics. And extreme heat weather events also cause displacement. This is not breaking news. We all know about this. And this also leads to outbreaks of diseases like measles, cholera, and malaria. So this is how climate change is affecting the pattern, the spread, and distribution of infectious diseases in our communities. Now, in Nigeria, most priority climate-sensitive diseases include malaria, chikungunya, dengue, cholera, Lassa, and then the emergence of AMR resistance under heat stress, and then distorted epidemiological pattern due to climate change. So recently, we are seeing distorted pattern of diseases. For example, if some diseases are known to occur in certain specific environments, recently there are changes. We are seeing changes. These diseases are occurring in other environments due to climate change. So why resilient? Why does it matter, and why is it needed? The first thing we need in this space, that is climate and infectious disease interface, we need to generate actionable evidence quickly. We need to show that there is specific evidence that climate change, for example, extreme heat exposure, is leading to outbreak of certain disease in some locations, or is leading to increase in AMR resistance in some disease-causing agents, or is leading to distorted pattern of disease distribution, susceptibility, and even virulence, and so on. So we need to increase our effort in conducting research in trying to bring out these specific evidences showing effect of climate change on infectious disease pattern and their distribution. This will help us to predict outbreak patterns under climate scenarios. For example, maybe during flooding, we'll be expecting to have some outbreaks. During extreme heat events, we'll be expecting to have so outbreaks, and so on. This will in turn help us to mobilize funding that is aligned with global climate agendas. So what we are talking about building resilience, what does it mean to build resilience? And what do we mean by research resilience, especially focusing on climate and health? So if we are talking about resilience, we need a situation where we will be able to sustain high quality research even during crisis, and not stopped in some conditions. And then this research need to adapt to climate-driven changes in disease pattern. And then we need to maintain institutional continuity despite funding or logistical challenges. I'm sure we all know this is one of the critical areas where there is need for improvement. to maintain continuity and sustainability, even with logistical and funding challenges. Because I have seen many funding projects that have stopped immediately after the funding finished or ended. This has shown there is no continuity and there is no plan for sustainability. And then another key aspect of resilience is collaboration across sectors. As I said earlier, climate and health research need collaboration from various experts from different disciplines. So in order to build resilience, we need to have effective and strong collaboration across disciplines, which I will talk about later. And then we need to be able to translate the data into policy. There are many researches that have been conducted, but then after finding and then after publication, in most cases, it's stopped there. So we need to do more to promote or to advocate for policy change. So this is one key aspect in climate advocacy, that what we found as evidence in our research, we need to use it to advocate for changes that will bring innovative solutions to our communities and interventions. And then, so that shows that resilience is not only scientific, it doesn't depend only on finding from our research, it is financial. So we need to get funding. It is institutional and ethical and collaborative. We need to build network. We need to collaborate with all relevant stakeholders. In such a way, we will be able to build resilience, climate and health, or climate infectious disease research network. So aligning research proposal with global priorities. So after identifying the problem and in trying to build networks and apply for funding, one of the key areas that need to be focused on is interdisciplinary integration. As I mentioned, we need to bring everybody in, anybody that has something to play and has a role and has expertise. So we need to bring that person into the network or into the group that is applying for the funding. And then we need to direct or strategize our application to have community impact. We need to look at localized adaptation solutions. What local resources are we going to use to develop sustainable solutions for our communities? So we shouldn't be much focusing on resources that are not available in our own localities. It is always better, and sometimes those funding organizations will be looking at your capacity or our capacity to use what we have currently to develop innovative solutions to solve our own problems, because nobody will come and solve our problems. We are the ones that will solve it. So we need to look at available resources, because whenever we use locally available resources, those innovations or interventions are likely to be sustainable. Then policy alignment, we need to align the work or the project with national climate adaptation plans and plan advocacy strategies in order to advocate for implementation or policy modification based on what we have found in our research using our locally available resource. And definitely we need to look at who are affected most and where in order to address or to direct our funding applications, especially, for example, children, women, and informal settlements like the IDPs and so on. Then our proposal also need to incorporate aspects of training and mentorship. This is another strong area which funders are looking at. In most of the applications for funding, they will be looking at how that proposal is promoting training, mentorship, and institutional strengthening. So when we proceed to writing competitive proposals, what are the key areas that we should address? The first is we need to frame the problem. What is the clear problem we are addressing? And this is very important right from the beginning. If we are not able to come out with the problem, then most of the proposal will not be strong. But if we have strong problem in our community that we are able to identify, then and we frame it in such a way that and come up with ways to address those problems, and then fit the problem with funders' priorities, because all the funders have their own priorities. So we can fit our problem that we have identified or challenges faced in that community to the funders' priority in order to be able to align with the objectives and the vision of that funding call. And then another important aspect is we need to have strong preliminary data. So I think in this regard, I would like to call on all of us to try as much as possible to start somewhere, especially the young researchers. And we need to start somewhere, because if we have some pilot studies that we have conducted and we have preliminary data, we are likely to be highly competitive in our funding application. Because if we compared those that have data already, meaning they have started something, and those that are without any data, those that have preliminary data are likely to get the funding because they have done something, they have learned some lesson, they have got some experience, and they will be able to expand on what they have started already. So it's always good to us work together collaboratively in our institutions and in our societies to conduct some pilot studies, especially regarding climate and infectious diseases or climate and health research. And when we have the data, we can definitely look for specific funding, and we have strong backing for that. And another aspect is the realistic budget. This is another area where usually funding applications can be rejected. For example, our budget should be realistic. What we have outlined in the budget should be within the maximum cap of the funding call. And even with that, we should know that those funding bodies might check and see the real cost of what we are applying for and what we are projecting, though not totally possible, but they have ways to do that. So we need to make our budget realistic, not making it beyond what we can do or less of what we have projected. All this can cause or can lead to rejection of funding application. Then we need to recognize relevant centers that we need to collaborate. Application as consortia or group is usually more strong than application as individual, though there are some funding calls that specifically target individual applications. But in most cases, when you apply as group of experts and relevant professionals that have a role to play in that field, you have a high competitive hand to win that funding, then applying as one center, as one individual without collaborative input or network. In this slide, I just highlighted some funding availabilities or available in the field of climate and health research. Wellcome Trust has a lot or several funding calls regarding climate and health. Some of them include climate health grants, discovery research, mental health and climate interactions. Just about some months ago, they have called for research funding on mechanisms linking climate change, especially extreme heat, to mental issues. And then we have Africa Research Capacity Grant, all under Wellcome Trust. Other international funding available include Bill and Melinda Gates Foundation, where they have the climate-driven disease analytics, mosquito control innovations, and health system resilience. There are many, and several ones. I'm sure some of the participants know even more and much better than me with regards to this. So in Nigeria and African region, we also have fundings that we can target regarding climate and health initiatives, especially the TED Fund and NRF grants, the Africa CDC Climate, Europe-Africa Clinical Partnership grants, and the African Academy of Sciences Grant Challenges Africa. We can apply for climate and health researches through these grants calls or available funding. Now, having said all this, as I mentioned earlier, I will talk about collaborations in climate and health research. As long as we want to build sustainable research, collaboration is non-negotiable. As I mentioned, in climate and health space, many experts have a key role to play. So we need to form network. We need to collaborate with this expert. For example, we need meteorologists, people that study weather changes and temperature. We need microbiologists. We need genomic scientists. For example, most of these disease-causing organisms, in some research, we have to study them, which strain is circulating, and that will depend on sequencing. When we sequence their DNA to find the local strain that we have and the ones that are abundantly circulating in our own community, and if they have some characteristic genes that are promoting or enabling them to have resistance to antibiotic treatment and so on, and also genes that have or enable them to be resilient to climate changes, especially extreme heat events. We need epidemiologists, we need geospatial analysts, we need environmental scientists, we need AI and machine learning modelers, and so on. So anybody that have a role to play, we need to bring them together. And the more we have these experts in our network or group, the more we have chance to win a fund or research grant. So if we identify the relevant stakeholders, how do we collaborate in climate and health space? What are the key aspects that we need to emphasize and look at? So we need to identify and connect with relevant local partners if we want to build strategic partnership, and then join global networks. One of those networks is Global Climate and Health Alliance, a very large and strong global network for climate and health actions, advocacies, and policy reforms. Just recently, we have worked through this network to submit what we call health community recommendation to Conference of Parties, COP30, that have just, I think it has concluded in Brazil. So these are the things from where we are, we can contribute to global activities through the Global Climate and Health Alliance. And there are many more organizations that we can partner with or we can join to build strategic partnership. We also need to promote university-industry partnership. This area, I can say we are a little lagging behind because we need to build strong relationship between university and industry, because that will promote funding even from those industries that we are partnering with, and we will be able to develop sustainable interventions for our own local communities. We need to partner with genomic centers and engage NGOs that are working on climate adaptation. So what are the effective collaboration principles? Right from the beginning, we need to define clear roles and expectations. And this is in most cases where some collaboration fail, where they go wrong. Because if we don't have clear roles to play, and we don't have clear expectation, as we move on with the collaboration, then we don't have specific duties or roles to hold the partners or the collaborating institution responsible. So we need to have clear roles right from the beginning, and what are we expecting from each collaborating institution? And there should be mutual benefit. It shouldn't be just unilateral relationship. It should have mutual benefit, meaning all the institutions collaborating should benefit from it. Then we need to have data sharing agreements. If we conduct a research, how are we going to share the data? How are we going to publicize? How are we going to manage this data that we have generated together? Then ethical frameworks, which are necessity for any research or projects. And then one of the most important aspects is sustainability beyond funding cycles. We need to come up with plans to sustain those activities or projects or whatever we are doing beyond the funding cycles. So if we plan that the funding cycle will be for 3 years and we are able to get it, what happens after 3 years or 5 years or even beyond that? After the funding, the project will stop or what? So we need to come up with sustainability plan. And this is also very important in any funding application. And this is what most of funding organizations will also be looking at. How are we going to sustain this innovation or solution after funding? And this is why I said we need to really work on using our locally available resources to address our own challenges, especially in the climate and health space. So in strengthening institutional climate infectious disease research, let's take these steps. One, as right from this moment, I'm sure there are a lot of climate health research clusters, but we need to build more groups that are working on climate and health interface with infectious diseases. And then we need to establish mentorship pipeline for young scientists. We need to train, mentor young scientists to build their expertise and to become experts in this space of climate and health infectious disease interface. We also need to invest in genomic research. As I mentioned earlier, most of the current researches are conducted at molecular level, and then modeling and environmental surveillance capacity. We also need to have internal grant writing teams. I'm sure, or I hope that this society have its own various internal grant writing teams. Even in our own institutions, we need to have internal grant writing teams. Maybe in every department or every group, we need to have teams that are writing grants, because the more we write grants, the more we learn.
Hello, Sam.
We lost you, sir. We can't hear you.
Hello, sir. It's like we lost Dr. Bashir because we can't hear you, sir. If you can hear us, maybe your network is shaking. Hello, Dr. Waziri, sir. Can you hear us? Hello, can anybody hear
He's
me?
still on the call.
Yes, he's still okay. He's still on the call,
but
yes, but
I
it's like we've
can't,
lost him.
I can't hear him.
Yes. Have mercy.
Sorry, Dr. Bashir has some technical issue, but he will soon join us. He's trying to rectify the technical issue. Sorry.
Hello, Dr. Dalhat. Were you able to contact Dr. Waziri?
Yes, I contacted him. He's trying to resolve the issue. He's joining us soon. Sorry,
Okay.
please.
Hello, fellow colleagues. Just to announce that we're able to get the recording from the third speaker. So the link will be shared in the group chat so that we can all download and then listen to the lectures in our own spare time. Since even if we take it as a group, we won't be able to answer any question and answers or any clarification. So I think it would be wise enough to just download the lecture and then we can listen to it afterwards. Thank you. So IT, please, I learned that the link has been sent to you. If you can just share it on the group chat so that everybody will have access to it.
Okay, no, I'll share the link. I'll share the link.
Okay, thank you.
Senior colleagues, we are very sorry Dr. Bashir is having network issue, but he's trying to resolve to change network from the one he's currently using. We are so sorry, please just be patient with us. Sorry, it's the technical issue and it's beyond our control, but we'll try to resolve it as soon as possible. Thank you.
Hello, so I hope you can hear me now. Sorry, I have some network issues. The network just. Please confirm if. Hello.
Hello, sir.
Yes, we
Can you
can see
hear
and
us,
hear, sir.
Dr. Waziri?
I can
Yes,
hear
we can
you.
hear
Can
you.
you hear me?
Yes.
Yes, sir, we can hear you, sir.
Okay, okay.
Mhm.
So are you seeing my screen?
Yes, sir, we can.
Yes, we do.
Okay. So just to round up, talking about the opportunities at Kano Independent Research Center. So I mentioned that we have some laboratories where we can collaborate with and explore opportunities with infectious disease experts, researchers, and students from all parts of Nigeria. So in this laboratory, we have 3 subunits. We have the genomics and molecular biology lab, where we do nucleic acid extraction, PCR, and gene expression assessment, and sequencing. So we also have plan to expand for proteomics and metabolomics. So this subunit is an area where researchers from all parts of Nigeria can connect with and see how they can conduct some innovative research and also collaborate with the Center for developing, sorry.
Please, who is there? Please, can you unmute yourself?
Thank you. So we can explore opportunities for collaboration and networking. And then in the center also there is microbiology and AMR lab, where they do media preparation, culture, AMR research, microbial genomics, and then they have future plans for virology and tissue culture. And then we also have the BSL-3 reference lab. Initially, it was designed for TB research only, but then the plan now is to expand it for research of diseases, especially in outbreak situation. So it will serve as reference lab for training also and surveillance of response team during disease outbreaks. So these are some key equipment present at the center. Here we have the Quan Studio, the one with 12 on it is the Quan Studio 12K Flex, where a machine that supports real-time PCR for gene expression. In addition to that, it also used for genotyping. So it is applicable to various research where we can have genotyping analysis or even mass screening of genotypes that maybe are susceptible to climate and health diseases and so on. And then also it is used for gene expression, as I said. Then the one below it is the Prometheon 2 Solo, though appearing a little bit small, but it is mighty because this equipment can conduct the whole genome sequencing of human being, which is about how many base pairs, like 3,000 or even beyond that, 33 billion base pairs. So, and then we have the GridION, which is also from Oxford Nanopore Technology, and is used for sequencing, real-time sequencing. When you are sequencing, you will be able to see the run, and you will be able to be seeing the base call, those bases of adenine, thymine, guanine, and cytosine. You will see them in real time while conducting the sequencing. And one important aspect about this GridION is if you are not getting a quality sequencing read, you can stop the sequencing while it is taking place. It is the only machine, the ONT, they are the only technology where when you are sequencing, you can stop it in real time. In other technologies, when you start, you have to finish, whether you are getting quality reads or not. So, but this allows you to sequence in real time, and you can do long read sequencing. You can see structural variations and so on. Then the one below it is the MiSeq i100 Plus, which is released to the market last year in October 2024. And I think currently in Nigeria, we only have 2 equipment to the best of my knowledge. So it is used and it's highly cell-friendly, and it has the analytic software incorporated in it. So it is very easy to use for sequencing, usually low throughput and short read sequencing because it is from Illumina technology. And the one from extreme right is the NextSeq 2000, which is a higher version of the MiSeq. And this one can be used for large throughput or high throughput sequencing, but it's also a short read sequencing. It doesn't allow for long read. So these are some key equipment that I think we can utilize from wherever we are from. From Nigeria, we can see how we
I think we've lost Dr. Bashir again. So if we can quickly type in our questions or clarifications in the chat box, maybe so that he can start responding to those questions, so that we can quickly wrap up the session and then do other things. Thank you.
Thank you, Dr. Zainab. I think the best way to go, to let the participants, we are sorry for the technical issue. Questions, please, can we jot down the question in the conference platform so that we'll collect this question and forward to Dr. Bashir, and his response will be sent back to the platform. Thank you. Over to you, Dr. Zainab.
Okay, I think that is great. Thank you for that, Dr. Abdullahi. So once again, thank you very much for joining this call, this webinar. And we're grateful for your patience, for staying behind up to this time, despite the challenges with the network Dr. Bashir has been experiencing. So with this, I think I'll call on the president and then the chairman of the local organizing committee to have a word or two, so that we can wrap up the session. Thank you.
Yeah, thank you very much. I think it's to appreciate everybody for the contributions and all our speakers. Unfortunately, we had some challenges with the connections with the last presentation. Notwithstanding, I think his presentation was very insightful. There are a number of points there that are useful to all of us and also useful to our society. And I think we need to align accordingly. On behalf of the society, I wish to appreciate everybody that has found time to attend this pre-conference workshop. And as I said earlier on, it would be appropriate for the organizers, the LOC, to please summarize some key points from these two presentations and even from the third one that we're going to listen to that will be shared to all of us. So if we can have some key highlights from the two presentations that we can take as deliverables from this meeting, I think that would be very useful. Once again, I appreciate everybody for this participation, and we look forward to tomorrow's event, opening ceremony. Thank you very much.
Okay. Thank you very much, sir. We'll try and do that, summarize the two presentations, including the third one, and then we'll now share it on the general group for everybody to have access to. Thank you. Prof. Adiza, sir, if you're still on the call, do you want to say anything? I think he has dropped down. Okay, with this, I think we'll call it a day. And then once again, I would like to thank every one of us for joining this from the beginning to the end. And then do have a great day ahead. Bye.
Thank you and bye-bye.
Later